Hi, ladies and gentlemen. My name is Abdulelah Alhawsawi. I'm the Vice President of the Global Sepsis Alliance for International Affairs. And on this very exciting session, I'm going to be actually wearing two hats. I am honored to be moderating the session, but at the same time, I have a quick presentation about the quality improvement initiatives for sepsis, and it's very much related to the title of the session, which is how combating sepsis is a great patient safety initiative. I would like to thank our sponsor, BD, for their continuous sponsorship and support of the sepsis work throughout the globe. So I will start with my presentation. And then afterwards, I will introduce our panelists for hopefully a great conversation. So make sure that while you're listening to the conversation, as well as to the presentation, if you have any questions, that you can type in your questions at the allocated time. So without a further ado, I am going to start my presentation. So the title of my presentation is How Quality Improvement in Sepsis Works at the Facility and the National Level. And I'm going to be basically talking about two aspects. One is to remind myself and everyone about the resolution that got passed back in 2017. And then I'm going to talk about the sepsis quality improvements, starting from the facility level all the way up to the national and the global level. So just a quick word about sepsis. Sepsis is a major global health problem. Every year, up to 50 million people are afflicted by sepsis, and 11 million of those die. So that represents around 20% of all causes of mortality worldwide. That's a big problem. And just keep in mind that even the survivors of sepsis may continue to have long-term sequelae. So prevention is actually the name of the game, you know, be it either in terms of vaccinations, hand hygiene, trying to avoid infection, focusing on high-risk groups, and awareness. It's important that we promote awareness, not just within the public, but also within healthcare professionals as well. So there are two ways to prevent sepsis. One way is to avoid infection. So prevention of microbial transmission and infection. So strategies and interventions like vaccinations, like hand hygiene, is important. Just keep in mind that there's also this linked and relationship between COVID-19 and sepsis. So the vaccination that is being done nowadays is also can be thought of as one of the strategies to prevent sepsis. The second strategy to prevent sepsis is to prevent an infection from evolving into sepsis. So let's say that we could not actually prevent infection from happening. How can we have a mechanism in place for early recognition and prompt intervention? So in 2017, in May of 2017, this magnificent resolution was passed. Thanks to the efforts of the Global Sepsis Alliance, led by Professor Conrad and his colleagues. And this was a big moment for the work on sepsis. That year, actually, more than 14 countries have introduced some systematic approaches to sepsis awareness, prevention, and intervention. I'm going to mention them by name just to say that, to give that recognition, but also to push for more countries to do more work. So the UK, the US, Canada, Brazil, Mexico, Ireland, and Kenya, Spain, Saudi Arabia, UAE, Sudan, Uganda, Nigeria, and Malawi. But as you could see, there are way, way more countries that need to also to do the efforts. In 2019, Australia, France, and Sweden have announced national sepsis campaigns. So this also kind of links to how, when we have a resolution with clear directions, that would help towards the efforts at the national level as well as a facility level. So the sepsis resolution had number of items. So the number one, it asked countries to introduce sepsis work into the national health system strengthening. It also highlighted the infection prevention and control aspect of the sepsis work, and how can we integrate that into the national level as well as the regional and facility level. AMR, antimicrobial resistance, is a big problem. So the resolution talked about antimicrobial stewardship and having those initiatives, at healthcare facilities and beyond is very much needed to prevent sepsis. Also, we have to have a standardized and optimal care. So that was the fourth item of the resolution. I talked about public awareness, and this was the fifth item of the resolution. So there's no way that we could bring the number of deaths and problems from sepsis down without addressing those, the public awareness, and without empowering patients and families. Training for all healthcare professionals about different interventions like the sepsis bundles, etc., and having those quality initiatives in place, which I will talk about in a moment, is important aspect of the sepsis efforts. Of course, we can do and improve without research. So research was as a big item of the resolution. Epidemiological surveillance is important, and the resolution highlighted the using ICD to establish the prevalence and the surveillance of sepsis throughout countries and regionally and globally. And finally, the sepsis resolution also introduced the World Sepsis Day, which is on September 13th. So make sure that September 13th of this year that you contribute to sepsis work in whatever way, shape, or form. Of course, the resolution also highlighted some specific asks from the World Health Organization as well. So that concludes the first part of my talk. Now I'm going to talk about the sepsis quality improvement initiatives. But just to give some basics of to some of the audience, there's something called the sepsis bundle or the sepsis 6. And just to be reminded about it, it includes 3 gives and 3 takes. So you give 3 and you take 3. So whenever you have, diagnosed and recognized sepsis early on, you want to give oxygen, you want to give IV fluid resuscitation, and you want to give broad spectrum IV antibiotics. So what do you want to take? You want to take appropriate blood cultures before you start in the antibiotics. You want to take blood for lactate, as well as you want to measure urine output. So timing is everything when it comes to preventing sepsis mortality. This study showed that any delay in sepsis recognition beyond 1 hour results in increased mortality. And it's pretty clear here that, the sepsis bundles I mentioned, you have to have a mechanism in place, be it in the emergency department, be it in the inpatient setting, to have early recognition. So you could actually start the intervention right away, which would save lives. The impact of antibiotics administration timing on mortality is also well established. So this study back in 2017 showed that delay in antibiotic administration beyond hour results in increased mortality from sepsis. This study also showed that based on our understanding of the importance of the timing of the intervention, you could see here that between 2011 and 2015 on the left-hand side, that the percentage of IV antibiotic administration for sepsis diagnosis within the first hour has increased. So that's a very good way to kind of implement the evidence of early intervention. This slide is basically borrowed from Bron Daniels, and it shows it's based on a database from the UK, and the red line shows the antibiotic rate use, and the yellow line shows the screening rate. And between 2015 to 2018, you see this very beautiful increase in the screening rate and antibiotic rate. And with that, you see a reduction in mortality. So again, clear evidence that early intervention with the standardized bundles would save lives. So now, over the next few slides, I'm just gonna talk about sepsis quality improvement initiatives at the facility level, at state level, as well as at the national level. So this study is from the US, and it basically, it was 18 ICUs in two states. It was Idaho and another state. And what it showed is the following. So the gray line is the percentage of compliance with the sepsis interventions and bundles. And the black line is mortality. And again, between 2004 and 2010, you see clearly that the compliance went from 4.9% in those participating ICUs all the way up to 73%. And with that, you see a very nice drop in mortality from 21 all the way down to 8%. So again, clear evidence that intervention and early intervention with standardized bundles would save lives. So what about state level? I have two states, one from New South Wales in Australia, and the other is from New York State. So the Sepsis Skills Program is a program that focuses on early recognition of patients that could potentially have sepsis, and immediate resuscitation and referral for specialized care accordingly. They have a very nice component to the program called Between the Flags. So is the patient between the flags? So remember that what I talked about, how we can prevent sepsis, which is either by preventing infections. So this is up here with the white arrow. But then in case that you have an infection, these are the flags. So this is where you need to intervene at the yellow line. This is the window of intervention that if you manage to have recognize the patient and activate the sepsis intervention, you could save lives. So again, this is the same idea with the flags, just to show you how this is implemented on an electronic health record. So these are the blood pressure lines, and you can see the yellow lines and then the red. So you don't want patients to be in the red. So these are the areas that you could say between the flags. The same applies for oxygen saturation as well as heart respiratory rate. So in 2013, the New York State mandated public reporting for sepsis, and they mandated also sepsis intervention. And it is clearly here that between 2014 and 2016, the risk-adjusted hospital mortality from sepsis in New York have dropped almost by half of what it was at the beginning. Sorry, by 50%. So what about at the national level? So this is a study from Australia and New Zealand, same thing. Early intervention with sepsis bundles shows reduction in sepsis-related mortality. Now, this is a busy slide, but I want you to focus on 4 countries that have introduced these interventions: Germany, UK, Australia, and the US. And 3 out of those 4 countries actually have managed to reduce sepsis mortality by 50% over 5 years. So remember the 11 million people that I mentioned early on that die from sepsis on an annual basis. Now imagine if all countries had 50% reduction in sepsis mortality. That is, you know, millions and millions of lives saved. So to summarize, I basically talked about the 2017 sepsis resolution with the different components of the resolution. There's a lot of work that still needs to be done by both member states as a WHO. So, you know, from this Congress, I ask, you know, the WHO and all stakeholders within member states to do more efforts actually to address this very important global health problem that is claiming millions and millions of lives. I've also talked about some of the interventions, you know, the sepsis 6 bundles. These are very basic bundles that, if present in the right department and, you know, and acted upon by the right people, we could save, you know, so many lives. And the evidence, I hope I convince you by now that the evidence is pretty clear that sepsis quality improvement initiatives would improve sepsis-related morbidity and mortality, both at the facility, state, and national level. So with that, I would like to thank you very much. And what I will do is, if there are any questions for my talk, we could take those questions while we're doing the panel. So now I'm going to wear my other hat as a moderator and the chair for the session, and it would be my honor to introduce my you know, great and esteemed panel. So starting, I'm going to go into alphabetical order. So Dr. Neelam Dhingra Kumar is a panelist. She heads the recently launched WHO flagship initiative, A Decade for Patient Safety, between 2020 and 2030. She leads the Patient Safety and Risk Management Unit in the WHO headquarters in Geneva. She leads the WHO's global efforts to providing strategic leadership in patient safety within the context of the universal health coverage. And that includes the implementation and the great work that she's done for the passage of the World Health Assembly resolution in 2019, titled Global Action on Patient Safety. So she also led Blood Safety Unit after joining the WHO between 2000 and 2014. And she coordinated the WHO efforts in areas for patient safety and risk management. So that is Dr. Neelam. And then next is Mr. Alan Donnelly. He's executive chairman of the Sovereign Strategy. Having founded the company in 2000, he also currently serves as a non-executive director of Cosworth and on the council of the University of Chicago's Harris School of Public Policy. He's the convener of a not-for-profit called the G20 Health and Development Partnership, which has done a great work advocating for healthcare agenda throughout the G20 and the G7 as well. Alan served as a Labour member of the European Parliament for 11 years from 1989, including a 2-year period as a leader of the European Parliamentary Labour Party. While an MEP, Alan specialized in economic, monetary, and industrial affairs. And you know, recently also the Global Sepsis Alliance has joined the G20 Health and Development Partnership. Next is Dr. Mike Durkin. He's a senior advisor on patient safety policy and leadership for the NIHR Imperial College Patient Safety Translational Research Center. He's a director for the academic partnership for the Global Patient Safety Collaborative, launched in collaboration with the WHO in 2019 by the WHO and the UK government. He's a visiting professor at the Institute of Global Health Innovation, Imperial College London, and the University of West England. He's an associate non-executive director of the NHS Resolution and a chair of the management board of the NICE National Guidelines Center. He was instrumental in actually helping establishing the Global Ministerial Summit on Patient Safety, which started by the UK and Germany back in 2016. And he was the NHS National Director for Patient Safety between 2012 and 2017. So next is Dr. Friedrich. So he's a chief medical officer for the Office of Quality and Patient Safety within the New York State Department of Health. He currently works with the New York State on the New York State COVID-19 response, assisting the governor and the Department of Health. He's also the leading statewide development of quality measurement and improvement programs. He's responsible for innovative quality improvement programs, such as the New York State Sepsis Campaign, public reporting on cardiac services and stroke, office-based surgery, antibiotic stewardship, prenatal care, and other statewide programs. He's a practicing primary care physician providing HIV care in the Albany community. Next, we have Dr. Günther Jonitz. He's a physician and surgeon by heart and education. He served as a president of the Berlin Chamber of Physicians from 1999 to early 2021. He initiated and founded the German Coalition for Patient Safety in 2005, which is a leading institution in Germany. As a technical advisor to the German Ministry of Health, he contributed to projects within the European Commission and the Ministerial Summits on Patient Safety since the beginning of the Ministerial Summit series. And last but not least, Mr. Kawaldip Sehmi. He's the CEO of the organization International Alliance for Patients Organization. He has an academic background in public health and law and has a passionate belief in improving access to services throughout digital health and justice services. As a managing director of an international children's legal center, he led a team of international lawyers improving the rights of the child, including right to health, by applying remote courts. He has also served as a chief executive officer for an international mental health charity specializing in niche mental health services, supporting young people and adults with complex mental health. So as you could tell, we have this esteemed panel. And let me just set the stage before I ask every one of them for their opening statement. You know, again, we have 11 million people that die from sepsis on an annual basis. Up to 50 million people that get sepsis on an annual basis. In New York, in the US alone, sepsis treatment basically cost more than $60 billion US. So as you could tell that this is a big global health problem, and I would say that it's overlooked. And basically, hopefully through our discussion, we want to highlight why focusing on sepsis is actually a great patient safety initiative. But then, how can we, through this hour of discussion, come up with some practical implementation efforts towards, be it either the resolution of sepsis in 2017 or the patient safety resolution in 2019, or many of the declarations that come out of the G20 throughout the years. So I'm going to start by asking Dr. Neelam Dhingra Kumar to make her opening statement. So Neelam.
Thank you very much indeed. And it's a great opportunity to connect with all of you. Greetings from WHO Patient Safety Flagship from Geneva. I'm really, really honored to speak at this panel at the World Sepsis Congress 2021. I must say, Dr. Abdulelah, absolutely, combating sepsis is a great patient safety strategy, and I fully support the topic of this session. As you mentioned yourself, WHO's work on patient safety is shaped by the World Health Assembly resolution, WHA 72.6, which was adopted in 2019 on global action on patient safety. And find relationship with sepsis, and particularly this resolution urges member states to integrate and implement patient safety strategies in all clinical programs and risk areas as appropriate to prevent avoidable harm to patients, which are related to either to procedures or to products or to devices. And it refers in particular to infection control and sepsis management, as well as to minimize the risk of inaccurate or late diagnosis and treatment. So I just want to emphasize that when it comes to sepsis and patient safety, there's absolutely, it's fundamental to have an integrated patient safety strategy to combat sepsis. And this strategy includes action by patients and families, by health workers who provide care, and by health system for effective, safe, and timely service delivery. As you mentioned, the importance of timeliness. So just on 3 points, to enhance the role of patients, there's an urgent need to increase public awareness on the risk of progression to sepsis from infectious diseases. And this can be done through health education, including on patient safety, in order to ensure that prompt initial contact could be made between the affected person and the healthcare system. Secondly, to equip health professionals, there's a need to develop and provide training to all health professionals, as you also emphasized as part of the sepsis resolution of 2017. There's training on infection prevention and patient safety, and particularly on the importance of recognizing sepsis as a preventable and time-critical condition with urgent therapeutic need, and also to communicate with patients and families to use sepsis as the sort of understanding of sepsis and to enhance public awareness. So there's a role of health professionals, very, very important, and to equip them with training and with capacity. And then the foundation of it is provided by the health system. So the importance of strong and functional health system needs to be recognized, which includes both organizational strategies and therapeutic strategies in order to improve patient safety and also to improve outcomes from sepsis. And for effective, safe, and timely service delivery, the health system needs to provide safe staffing levels, supportive working environments, create safety cultures, and strengthen teamwork and communication. So I think these are some of the opening remarks I would like to make, particularly to show the interrelationship between sepsis and patient safety, and how actually combating sepsis is an extremely important and a great patient safety strategy. Over to you. Thank you.
Thank you, Neelam. So next I'll go to Alan Donnelly. So Alan, if you want to give your opening remarks.
Thanks very much, Abdulelah, and it's great to see you in Saudi Arabia. And I want to congratulate the Saudi Arabian presidency and the Saudi Patient Safety Center under your leadership last year for putting patient safety so high on the agenda. And of course, the great thing is that the Italian presidency of the G20 has kept patient safety high at the agenda for this year's G22. I want to deal with how we engage political leaders in addressing this issue, because if we're going to achieve the Sustainable Development Goal 3, there are some massive things that need to be done. And of course, we're seeing this now with pandemic preparedness and response and the whole issue of antimicrobial resistance and so forth. But there are some things through accelerated progress where we could make a big impact on achieving SDG 3. And I think in relation to the figures you gave about the 11 million deaths and the 50 million people who are impacted by sepsis each year, with a concerted effort and with giving practical tools to people, we can actually make a big impact here when it comes to health system strengthening and patient safety. Some of the other initiatives that need to be addressed, of course, are considerably more complex, but this is not as complex as some of the issues that need to be addressed. As Neelam has said, training is a critical thing, very basic training. Also, I think we're learning as a result of COVID-19 that we have to record incidents that are occurring in the global health system. We've got to find a better way of measuring them so that people are using common standards to record how people are being affected or dying of some of these issues. But you know, the one thing you didn't talk about, but I know you've got the figures, and I know that the OECD have looked at this in a broader sense from the point of view of patient safety. The liability, for example, in hospitals across the world, I know just in our own national health system in Britain, the liability, financial liability across the world, where patient safety is compromised, perhaps through someone developing sepsis, or the social consequences of someone being disabled as a result of suffering from sepsis when they're then discharged and they're unable to participate actively in the labour market, which may impact their family or impact their own lives. For politicians who are not health specialists, we've got to present in very simple terms what is the socio-economic consequence of not addressing this issue, and what is the socio-economic consequence of addressing this, and what are the tools that we need. And so what we'll be doing, and we're delighted that the Global Sepsis Alliance, thanks to your encouragement, and of course, Professor Conrad, are part of the G20 Health and Development Partnership. We want to make sure that we look at this from a clinical point of view, but in order to address a much wider political group of people, what we need to do is look at it from an economic perspective too. And we're doing it successfully now in the G20 Health and Development Partnership by advocating joint health and finance ministers meetings. And I hope that in the coming months, either during the Italian presidency or in the Indonesian presidency next year, that we can have a joint health and finance minister meeting look at the socio-economic consequences of properly addressing this terrible problem which impacts low, middle and high-income countries.
Thank you very much, Alan. So next I'll move to Dr. Mike Durkin. So Mike, for to give your opening statement.
Thanks, Abdulelah, and thank you also for the opportunity to join everybody else in what's a great panel and a great opportunity to work together across the globe. And there is a risk of repeating other people's views, which I think we're pretty united on, many of them. So I will try and just concentrate on what I think are some of the learning points that we've developed over our national patient safety improvement program over the last decade or so. And obviously here I really do want to echo Jeremy Hunt's view in terms of supporting the work that Ron Daniels has led across with the Sepsis Trust across the UK. But we also have to recognise that, as was described by Jeremy, that this is as much a cultural concern than it is a technical concern. And in that cultural concern, I also recognise Alan's point about the socioeconomic element to it. And if we marry those cultural issues and the socioeconomic issue, then this becomes a key, not just a key safety element, but it's a key structural change that we need to put in place across our systems, that these ever-going and ongoing issues of safety and quality need to be at the highest level of our system, whether that's the system at the hospital level, at the board level, whether it's at the system in terms of local government or regional government, or whether it's at national and global government level. We need to make sure it's at those levels that these discussions are taking place, because we can no longer put up with the differences that occur across our nations and the differences that occur in terms of the costs and the resources we're putting into place. That's my first point. The second one, I think, is to recognize what Jennifer said in her opening work, Jennifer Gardy, earlier. about the need for a national integrated surveillance program. And I think I would suggest we need an international integrated surveillance program for this work. Now, we know that we've produced elements of those in terms of the dashboards that you've identified from the countries that you demonstrated in your piece. But we need to do this on a global system, and we need to also therefore agree on a common set of standards for that, a common set of, as Alan says, reporting mechanisms. We need leaders to be put in place and support the resources that need to be put in place at a local level, whether that's owned at a national system like ours, or whether it's a multi-system approach to healthcare. We need to put those in place. The third element is the one that I think is recognized by this Congress, and that is the leadership challenge that is required to ensure that not just the patient and the family are really placed at the center of their own model of or pathway of care, but the healthcare workers at whatever level are also placed at the center of the discussions that are taking place. And we now know, particularly over this last year, and I'm sure it will be continuing for many months to come, the impact on healthcare worker safety with regards to ongoing issues with this current pandemic. But that has always been the case, and there have always been healthcare workers who've suffered either through nosocomial infections or the lack of attention to their care from good infection control prevention methodologies. And that's the other element, is that. But this is a global as well as a national and local challenge, and as such, we need to continually learn from each other. So the other element for me, in terms of even if we have an integrated system of surveillance, we need an integrated system of learning, and that needs to take place at a global collaborative level, where there are no major leaguers here. We're all in the same league together. This isn't a Premier League versus a lower level of soccer. This is a global system for all of us to work together and support each other, as has been laid out by by Dr. Tedros and his aspirations. So in the UK, just briefly, what we've done is try to integrate those processes in terms of dashboards, in terms of using early warning scores, the Royal College of Physicians news score, to try and also ensure that there is an ICP control toolkit that is absolutely at the corner and cornerstone of everything we do. But this has to be seen, and it was mentioned once briefly by Christopher Murray. I think this also has to be seen within the continuing growing context of antimicrobial resistance and the inexorable rise of gram-negative bloodstream infections, particularly those on E. coli. Because unless we also recognize this importance, then we will be losing a lot of the armamentarium that we have to be able to support the rapid introduction of appropriate antibiotics when they're needed. So the recognition that these are dual elements that we really need to work on at the same time. So we create a systemic as well as a systematic approach to improving the care we offer our patients in whatever setting, from not getting serious infections. Thank you. I'm sure I'll come in later. Thank you.
Thank you very much, Mike. So next I'll go to Dr. Marcus Friedrich.
Thank you, Abdulelah. And I agree with you. I think that sepsis is a great patient safety strategy, but also could be a great health policy. And what we've done in New York State is just one example. When we started back in 2010, 2011 to look at the data, there was a huge variation in mortality by hospitals, in hospital mortality by about 5-fold. And I think what you mentioned earlier was this because sepsis was mostly overlooked is probably a question, or what Mike was just saying, that it could be a cultural problem. And we thought that we would take this head on. And we passed a law in New York State that we called Rory's Regulation in honor of Rory Staunton, where that had 3 pieces. First, that we mandated that the hospital should have evidence-based protocols in place, because we just think that that was missing from a global approach here, at least in New York. That we also, the second component that Mike just mentioned, the training component, we thought was important, that the hospitals need to train their staff on that. And then the third, that they would share data with us. And the law is in place since 2013, and you already, Abdulelah, in your presentation showed like the results are pretty impressive. It's not 50%, but 30% absolute reduction, which is really a result of improving care by the hospitals to the patients here in New York, and also saving lives. And, you know, what better patient strategy could there be by, you know, directly saving lives in reducing the mortality from sepsis in these hospitals? Thank you.
Thank you, Marcus. So next I'll go to Dr. Jonitz.
Hi there, everybody. Thank you very much for the invitation. I don't know how long my connection will work from here, so I try to make it short. So first, thank you for the action against sepsis, because it teaches us a lot how to deal with special health issues and special threats. But if we want to come to real outcomes and to a real change in healthcare, we have to act on two levels. The first one is the political level. That means that politics very often is about numbers. So how much do we spend for antibiotics, for hospitals, for nurses, and not enough about humans. And very often political leaders are organizing systems that are organized like an assembly line with people working one after the other instead of together. And to be successful on the political level, it's quite simple to change the strategy from decimating diseases, decimating costs, decimating maybe too much hospitals, into a strategy of optimizing care. And if you put it in a question, then you just ask, how do we optimize care in Germany or in Saudi Arabia or where else within the next 10 or 20 years? And you will get a lot of answers. Secondly, if we want to promote patient safety in special, we have to put it also in a positive frame, because patient safety is not a funny issue. Neither sepsis is. But if we see it as a chance to take action to provide better care, we do good things for patients and also, of course, good things for the caregivers. So once again, a positive frame is very important to be successful with your political actions in healthcare. And if I make it even shorter, there was a business model in the past saying promoting fear, selling hope. And I think the future business model will be promoting hope, selling solutions. And selling solutions, and now I come to the second important level, is the level of the caregivers. All my speakers before me have addressed the importance of caregivers, of doctors and nurses, to recognize sepsis, to act on patient safety, to tell the right diagnosis, and to act as soon as possible. And so we expect as a society, and from the patient's point of view, an utmost level of professionalism and humanity. And when you look at the working conditions of caregivers, it's absolutely the contrary. So maybe not to professionalism, but especially to inhumane working conditions. So if we want our patients to be treated well, we have to treat our doctors and nurses well. And when you once again look at how to promote it, better care, you can learn from sepsis that it's not the doctor's issue or maybe the patient's fault, but it's teamwork, because everyone is able to somehow find out that there's more than something not in order with a patient with more than 38 degrees Celsius. So it's teamwork, it's a question of awareness, and it's a leading question if we have enough time for care, and which might be quite new, if we have time to talk, to create teams. Because normally most doctors and nurses are working like Charlie Chaplin at an assembly line, being very exhausted at the end of the day. And future care means we have teams, and teams talk to each other and talk to the patient, and they talk before an event. And of course, they talk after an event, and this needs time. and this needs money. And I think investing money in humans and in working conditions might be the best thing to provide better care. Thank you.
Thank you very much. So next I'll go to Kawaldip Sehmi from IAPO. So your opening statement, Kawaldip.
Thank you, Abdulelah, and the board of World Sepsis Day. I think I'll start off by saying that we have a great opportunity in the WHO's Global Patient Safety Action Plan 2021-2030. This is the driving force for us now to look at how our health systems look at everything, and that includes sepsis. So it really neatly fits in. For the next 10 years, we have this great opportunity to push everything in its slipstream. Second, I think we have to really look at how the whole spectrum of prevention to care, and then also to rehabilitation, once after the sepsis recover, and even palliative care is reappraised afresh with the view of how patients can be engaged in this. Patients can, one, bring in insights that may be able to make things more effective, maybe improve the reach, most definitely improve the efficiency of the programs. And lastly, I think very important is that patients can add to the information and education and undo some of the misinformation and infodemic problems that we are having. So patient engagement and co-creation in sepsis is critical, and so is it critical in the World Patient Safety Action Plan 2021-2030. Thank you.
Thank you very much. So I'm going to go back to Dr. Neelam and ask you. Let me put it this way: every year, 11 million people die from sepsis, and according to we know that at least in low middle income countries, 2.6 million people die from unsafe care. On an annual basis, AMR kills 700,000 people, and by the year 2050, if we don't do anything to AMR, 10 million people will die from AMR on an annual basis. Now, we've got a number of resolutions. We've got the World Health Assembly's resolution. We've got declarations from multilateral organizations like G20, etc. Why is it that we're still having an implementation problem? And maybe if you could answer this question, thinking through your great work on the 2019 Global Action on Patient Safety Resolution, and how can the 2017 resolution would learn from some of the efforts that you've done in combating sepsis?
Thank you, Abdulelah. The resolution on sepsis and the Assembly resolution on patient safety are very complementary to each other. And as you recognize that the resolutions are policy statements, which is the commitment by governments from around the world to take action on a particular topic and prioritize it. But there's a gap in when it comes to national prioritization, and what is required is building the case and actually looking into the local data. What are the real issues? So there's a need for prioritization at national level, and where international partners, WHO, and organizations who are working on the area of sepsis and patient safety could be facilitatory. So I think the implementation gap is primarily because of lack of prioritization at country level. And it is really important for us to invest into looking into where the gaps are, whether there's a knowledge gap, or there's a policy gap, or there's a delivery gap, or there's a communication gap, and how do we fill up and in the implementation gap by addressing these gaps either in knowledge or in policy or in delivery. And with prioritization come resources. So until and unless there is some sort of institutional framework and resources to implement the program, we will not find sustainability. So resolutions, of course, identify the key strategies which need to be implemented. But when it comes to actual implementation, it requires policy, strategy, plan, and institutional framework with clear roles and responsibilities at national level, working with partners and, mainly the civil society and professional organizations, and most importantly, to have patients and families and communities engaged. And I must say, in this particular aspect of, just building on to what Kawaldip mentioned, that it is absolutely vital to utilize all opportunities of engaging with public and increasing public patients' awareness and engagement on very pertinent topics of patient safety and sepsis. And we are really, in this case, have a great opportunity to link with World Hand Hygiene Day, which is in 2 weeks' time, and also World Patient Safety Day, because these provide great platforms to highlight the issues, to engage policymakers, to engage patients and communities and stakeholders, so that there's ongoing advocacy and the need for prioritization is maintained, and it is backed with sufficient resources as well as institutional frameworks and systems to implement the actions which have been agreed. So just basically my opinion about what are the sort of several opportunities to fill this implementation gap. Over to you. Thank you.
Thank you, Neelam. So I'm going to move to Alan. And last year through the OECD report on the economics of patient safety talked about the financial and the economic impact of sepsis, which is only in the US, which was estimated to be more than $60 billion US. Now, just to follow up on the points you've mentioned about how to engage politicians and policymakers, COVID-19 last year killed around 2.6 million people, and it's a major pandemic, and there's this huge global response to it, which is ongoing. How come that a problem that kills 11 million people, not to mention the 50 million that not necessarily die but end up with all kind of long-term problems, how come this is not getting recognition and awareness by policymakers? Is it our problem as healthcare community that we're not making it available and reachable to policymakers, or is it more complicated than that?
Well, Abdulelah, up till the end of last year, Goldman Sachs estimated that G20 countries spent $12 trillion mitigating COVID-19. $12 trillion. I have no idea how much it is currently. I have no idea what the current figure is. And so when you think that just under 400 billion investments would have helped to deliver the SDG 3, I think what's happened is politicians now realize that global health security and health system strengthening is something that you have got to invest in. And so what we've been able to do, as you know, because you're one of our global ambassadors for the G20 partnership, we've changed the narrative now so that politicians talk about health investments rather than just health spending. And that means you've got to be able to measure the return on investment. And I think that if you think about some of the relatively simple measures, setting aside antimicrobial resistance, which is a more complex issue, but when you think of the issue of hygiene, some of the measures we're now working on with a number of institutes, including Harvard and WIFO, which is in Germany, on helping politicians to understand the return on investments in health. And I can tell you the problem with the whole debate about health in the past, and we found this when I first became the chair of the G20 Health and Development Partnership at the beginning of 2017, when health wasn't even on the agenda of the G20, is that that the whole debate in health operates in silos. So you have disease silos where the experts get together, whether it's tuberculosis, HIV, AIDS, malaria, neglected tropical diseases, sepsis, antimicrobial resistance. And what we've tried to do, as you know, in the G20 Health and Development Partnership, is we've tried to improve access to basic information for politicians who are not specialists. And we've tried to get away from this siloed approach to the debate on health, because I think the reason why we underperform is that a lot of the information is too technical, because it's drawn up, and this is not a criticism, by the way, but a lot of it is put together by clinicians who are scientists and trained. And what we've been doing over the last few years is, simplifying the information. So, for example, the report that we published a few weeks ago, which I think you wrote the conclusions to, and Dr. Tedros wrote the forward to it, on patient safety, drew together a wide range of people, including the International Labour Organization, the head of the International Nursing Confederation, a whole range of people who are not scientific people, are not clinicians, but who understand that you've got to have a different sort of dialogue when you're talking about global health security. Now, we are making progress on this, but I do hope that now that the Global Sepsis Alliance is part of this partnership, we can look at disseminating information to politicians who deal with economic policy or climate change or all sorts of policies that are not directly linked to health in its very purest sense, to get that information out to them. Because I think by doing that, then what we can do is we can reach the people that Mike was talking about before, which are people out, the public health people out in towns and regions. And we can start changing the dynamics of all of this. And of course, the big thing is if we can work out what the return on investment is, then you can look at how you can repurpose that finance to deal with things like research and development into antimicrobial resistance or mental health services, or in low-income countries, it may be just basic access to diagnostics and so forth. And that's why I think we have to link the economic and the health arguments together in the same way now that climate change and economics are irrevocably linked together. Because if you do that, you get a much broader group of politicians who will look to take up your arguments and help to find solutions.
Thank you, Alan. So Mike, you've talked about something that I'm very much passionate about, which is this whole notion of global learning. So having a system in place for global adverse events as well as global learning. Now, the biggest issue is for us to have a global learning platform, we have to be using the same, taxonomy. And that was kind of behind the reason behind the efforts for the Jeddah Declaration to have the International Classification of Disease as a foundation for international classification of adverse events, which we don't have. I think we still have an opportunity because the ICD-11 will go in effect in January 2022. So, and I've had discussions with some of the task force from the WHO, and they're still open to the idea of the ICAE, International Classification of Adverse Events. So just from your perspective, what do you think about that? And you did talk about IHR, which is for surveillance for infections, but then we don't have an equivalent IHR for adverse events, and whether or not it's time to kind of think about having a global surveillance system for adverse events as well, not just necessarily for infections.
So thanks, Abdulelah. And also, I think we have to thank the ministerial summits that was held in Jeddah that actually really brought to the fore the issue that we've all faced with, which is that we don't speak with a common language. We don't have a common language for what would be arguably the biggest issue for patients who are fearful that something will go wrong at some stage during their care, and that we then may not look after them appropriately after that, or even during the continuing piece of care. And it's very sad that we have to recognize that we don't speak the same language. So the drive to create a common taxonomy through the new ICD-11 approach is onwards is a great thing to try to do. Just as an example, so there are many different codes, therefore, that someone could put in that would be classified as an infection code or a sepsis code or, across the current system. And if you look at some of the other harms that we have that are also very, very cost accelerators in the system, say, for example, blood clots and venous thromboembolia, there are currently 47 different codes that someone could put in. So we have a very limited approach into how we can actually work together to speak with a common goal. So a key thing, therefore, is to come up with a solution for this. I think it has to be geared around the taxonomy, but it also has to be, I think, probably in one where we also link this with the other driver for change. And this is the piece that Alan was talking about in terms of the cost benefits to the systems. Now, we've started to try to do this work in terms of a collaborative learning approach with the great offices of WHO in setting up a global patient safety collaborative for low and middle-income countries. And we've started that with the first 4 countries. And you may remember that's India, Kenya, Mongolia, and Pakistan as test beds, really as test beds to try to see how we can work and create a common language of training and education, of leadership support and development, and of research capacity and capability. One of the key elements that keeps coming out when we're talking, and this year we have been limited by doing all of our talking on Teams or Zoom or platforms such as that. One of the common elements that keeps coming up is what about our reporting systems? How do we help and enable our reporting systems to be better? But also, how do we make them appropriate and accessible to not just staff and healthcare workers at every hierarchical level, but also patients who also would like to have access to these systems. And so I think one of the elements that we're learning now is that this is a common issue, and healthcare workers inevitably want a common platform. So I don't think there's necessarily an issue at that level. There was an issue, I think, and probably in some systems there's an issue of fear of reporting and fear of reporting when things go wrong, in case that you might then face repercussions for that. And so that brings us up into this question of how do we create a reporting system that acknowledges a just culture that doesn't get in the way of accountability. So when you report something and it is by a failure of action that you should have done, then you are accountable for that. But inevitably, we want a reporting system that creates an appropriate just culture for that reporting. I think what we found is that this can only happen. The collaborative is funded by outside sources from these countries because they can't afford to fund it themselves. So I think one of the key elements for us is to find a way of using the good offices of philanthropic systems and supporters, as well as WHO as a convening power, to come up with some solutions for this. Now, G20 and dare I say it, G7 could be an ideal platform for this, but it needs to be a cohort of countries that will work together. And I just also would maybe suggest that the test beds, particularly in a frugal innovation environment, would be ideally suited to many low and middle income countries who may not actually get to the table of the G20 group. So for me, it's how do we create that energy level, which is definitely a drive up. So it's a push. We don't have to pull. I think it's a push from there. So I think for me, it's let's set up some global exemplar systems at a frugal level and see whether it can work then. And then we drive that up through the system. There's no doubt that the healthcare workers on the front line and patients on the front line want this to happen.
Thank you very much, Mike. So I've seen a number of questions from the audience about how to reconcile this notion of early intervention with broad spectrum antibiotics And how do you reconcile that with antimicrobial resistance? So I think Marcus is very well positioned to answer that, given your work in New York State, and there is that fear. Is it justified, or does the evidence, is there an evidence that shows that we don't actually worsen AMR if we intervene early?
Yeah, I think this is a valid question, and I think that is also one of the concerns that we heard from frontline physicians, from ER physicians and workers in the emergency rooms. We have extensively researched that in New York, and we also have collaborated on papers to see if this is really an issue, the antimicrobial resistance that is driven by a protocolized approach. And we have found absolutely no evidence that this is driving up infections such as C. difficile infections in the hospitals or others. I still have to come across a study, a well done study that is showing that that the amount of antibiotics is actually on a bigger population health level harmful for what we are doing. Because I think on the sepsis side, it's always this balance between it is a high mortality disease process that sepsis is, versus being too much worried about the antimicrobial resistance. We have changed our approach to this, and we are educating the physicians and the hospitals to a quick de-escalation, to start with broad spectrum antibiotics and then to quickly de-escalate the antimicrobial therapies in the hospitals. And I think that people understand that. But I think the verdict is still out. I still hear now in 2021 concerns about this. And I think that we are currently engaging with a group of researchers on another project to look again at this issue. And we will probably have the data at the end of 2021, if not even 2022, to see if there is really a hint of evidence about this. I have not seen that so far. But again, it's a good question, well raised. But I think that as a physician, do no harm, and I think that the adverse effects from not giving antibiotic in a case of sepsis is probably weights like stronger and larger to me than being overly concerned about antimicrobial resistance that I might be driving through with these therapies.
Thank you, Marcus. So let me ask Kawaldip now. Some of the practical interventions when it comes to patient empowerment and patient and families empowerment in sepsis is patient and families activated rapid response teams. So what does IAPO think about that? Are you familiar with any literature that is promoting this intervention? Because it has to deal with the early recognition and giving. If you're in a clinical setting where the nurse is overwhelmed and the patient could be deteriorating without having someone actually activating such a rapid response team. So I think it would make a lot of sense to introduce such initiatives in healthcare systems and in hospitals, to have patients' families also be part of the team and train them about how they can activate such rapid response teams.
Yes, thank you very much, Abdulelah. I think this is where the WHO's patient and family engagement framework comes into play to patient safety, and it's obviously the AMR Action Fund as well was talking about the same issues. There are two demarcations and the two what I call great touch points. The first is the home, and there I think for younger patients, the parents concerned are the main recognizers of the early signs. So therefore, I think this intervention should be targeting towards them, including the carers into it. And the second is once the patient has entered into the healthcare system, meaning at the primary healthcare level, and then maybe even the tertiary at the hospital level. So we think the most important part is, as you said, to err is have a human, in patient safety approach that yes, we do make mistakes. So therefore, what you do is, for this instance, you say that yes, even if you have made a mistake, you don't think it's sepsis, but go to the hospital nonetheless. You make this red route right down to the clinicians. Moment you as a parent, you suspect, we don't care. You bring the individual in quickly so that a professional can look at it, and you can use some of the diagnostic toolkits to assess it. Because if you're wrong, we forgive you. That's part and parcel of this. So you need a red route right into that care system. Then once in the red route, once you're in the care system, I think this is where patients and families, advocates have to develop that framework of recognition and respect and being taken seriously. If a patient or their relative says, "I suspect sepsis," then the thing should be escalated. So you need what I call the double red line. That it's not only a single red route, it's double red route. That you ignore everything, like Rory's law was putting out. You just streamline it. It's better to be wrong than right in these issues. So it's almost with the COVID, we are learning the same lesson right now. That any suspected cases, please do the test, and then if you're wrong, that's fine. But we need to make sure that our health systems are sensitive and specific enough. That needs to be done. And lastly, I think the awareness program is a combination. I think it should be. I have been promoting sepsis recognition in schools, saying that this is part and parcel of teachers' curriculum. Then should be part and parcel of the curriculum of medical students. I think you and I were looking at the International Federation of Medical Students Association, and I remember when I asked them how many units do they do on sepsis in their course and training, and all of them, the majority, the 100 or so we spoke at the World Health Assembly when things were much brighter and we could meet. What they said was 15 minutes, and some even say it was self-directed study. So there wasn't this program, whereas this is a cross-cutting effect. It should be from surgery right down to simple interventions. Any invasive sepsis should be discussed through that. So we need to bring that in. And lastly, I think the level of home care, I'm sure we can do something much better in self-care side of things. We could get diagnostic kits that are cheaper and safer. Liquid flow tests are now available left, right, and center. They can be modulated. I think they should be introduced so that many of the health-prone patients, especially those who are applying care at home through using infusion pumps and have to punch your skin and issues, they need to be looked at. But as I said, it's the whole societal thing needs to be looked at, because this should be repositioned again. It should be that it's avoidable harm, and it is unnecessary to spend money on this. It's almost a sinful way of wasting precious health system money on this, which is preventable.
Thank you. Mike wants to come in.
Yeah, thanks, Abdulelah. So I just want to support Kawaldip in the elements that he was talking about, and it links back to your previous point, I think, about the silos in our system, and we have to recognise that even in the 21st century, in many systems and many local systems, there is a power dynamic, at play where our patients are not seen and their families are not seen as equal members of the journey that those families are going on. And families, we often talk about the patient being their best expert of their healthcare needs. They don't come to see us as healthcare professionals unless they often recognize that something is not quite right, or family members recognize with the children there's something not quite right. And then we negate that view of theirs once they've come into the institution. And I think we need to reset ourselves on that process. We need to reset it very quickly, I think, in the way that our systems are developing. And if we translate that into the hierarchies that we have within our own, if you like, at that level that you were talking about, where we have almost a war game going on between sepsis, between AMR, between the various interventions that could be taking place with the various systems that could work together. If we pooled our resources and worked together, we'd be so much stronger. And we'd have much more effect at the local level, because whatever we talk about at the sort of the ivory tower distant level, unless it's making a difference to that conversation that takes place between the patient or their family and the nurse or the doctor in their own local system, we're wasting our time. So we've really got to get a grip of that and start to work together in a much more cohesive and effective way. And use those people who are currently in place who are positioned to do that. As Alan said, let's get a grip with our politicians. Let's start to activate them. Thank you.
Thank you, Mike. Neelam?
Thank you, Abdulelah. I think it's a very, very important question about creating more synergies between pandemic preparedness, IPC, sepsis, and AMR for both, scale up action at national level and subnational level, and also actually making a difference at point of care. So I just want to share that the Global Patient Safety Action Plan, which WHO has been developing after mandated by the World Health Assembly, and it's been a more than 1 year long process, has really created some great synergies in bringing these programs together. And particularly, the strategic framework which has been developed for the Global Patient Safety Action Plan for next 10 years identifies the need for developing and sustaining multi-sectoral, multinational synergies in solidarity and partnership to improve patient safety and quality of care. And in this particular strategic objective, it identifies the need for fully engaging all stakeholders who have a positive who can have a positive impact on patient safety and have a common understanding and shared commitment. So Mike touched upon it, Kawaldip touched upon it as well, that common understanding and shared commitment of all stakeholders working on different programs so that we could successfully deliver the Patient Safety Action Plan. And creation of networks and consultative meetings to understanding the commonalities, and even multi-sectoral initiatives and cross-geographical initiatives can advance the action on patient safety. So I must say that the Global Patient Safety Action Plan provides an opportunity for creating synergies between these two programs at the national and the global level. But at the point of care level and also at the patient's level, I think there are also great opportunities for synergies. If we look into these 4 areas, healthcare-associated infections, AMR, pandemic preparedness, sepsis, and also I would add to it the safe and appropriate and rational use of medications. They're all very much interrelated. Just giving an example, inappropriate and excessive use of antimicrobials will lead to the threat of antimicrobial resistance. And in this case, sepsis actually represents the most vital indication for the responsible use of effective microbials. And in the absence of timely management of sepsis, including through effective antimicrobial, sepsis could be universally fatal if you don't really use timely and appropriately these medicines, the microbials. And so there are several tools WHO has created, and I think they can be extremely useful, particularly for engaging patients and increasing their awareness. Now I'm looking at the commonality between AMR, medication use, and also healthcare-associated infections, like the 5 moments for hand hygiene is an extremely important tool. which identifies the moments where in healthcare to prevent healthcare associated infection, which are the 5 moments where you have to make sure that the specific moments where hand hygiene has to be performed before touching a patient, before cleaning, and before having aseptic procedures, body fluid exposures, touching a patient or touching patient surroundings. So these 5 moments for hand hygiene, we now have also taken this concept for 5 moments for medication safety. And these 5 moments for medication safety also identify the 5 vital moments in treatment with medications where action can reduce the risk. So which is starting the medication, taking the medication, adding new medication, or reviewing medication and stopping medication. So the point I'm taking that patients themselves are the unifier. They are the ones which can really bring synergies into these programs, because ultimately, the patient is the one who has to be fully engaged and aware how to identify these risk areas in the critical moment where action by patients and healthcare professionals will reduce the risk of sepsis and also bring the synergies. So opportunity for synergies at global level, national level, and also local level, following the framework of the Global Patient Safety Action Plan, and through several patient engagement tools and strategies for engaging communities, we can actually bring synergies through enhancing the role of patients as well. So over to you. Thank you.
Thank you, Neelam. Günther, so you're back with us. Go ahead.
I'm deeply convinced that patients everywhere have the right to get and to receive the best possible care. And if you want to deliver best possible care, I think the key is how to get to the heart of the doctors and nurses. And funny enough, if you do not address doctors and nurses with new tasks or new regulations or new forms to fill out, but if you take action in terms of care for the caregivers, supporting them, teaching them how to communicate with patients in case things went wrong, how to communicate with other professions, then you reach several goals with one attempt. You get better patient safety, you get a higher workforce satisfaction, you get less burnout and less sickness leaves. So once we start treating caregivers as human beings and do everything we can do to support them to fulfill their mission, I think this would be key. That is quite a challenge on every level, especially also on the political level, because on the political level we talk about numbers and costs and so on. But we all have to keep in mind that it's about human beings with the caregiver side and also on the patient side. So humanization would be one goal for me to address better care.
Thank you very much. So we have 5-6 minutes left. So I'm going to ask every one of you for a minute kind of message about how can we reach zero harm. And I'm a big believer of zero harm. So these 50 million cases or 11 million deaths. So if you were to pick one strategy that could help us with the implementation, what would that be? So I'm going to start with Alan.
Thanks, Abdulelah. My signal's a bit weak, so I'm afraid I've had to turn my camera off. So apologies. I think the thing that could make the most rapid difference is the point that Günther made. I do think that there is a cultural problem within primary healthcare where if there is an incident, then the question is in many places people are looking for someone to blame, and I do think that we need to have a significant cultural shift so that if there's an incident, then the patient needs to be informed, the family needs to be informed, and the frontline healthcare worker needs to be supported. Because if we do that, then we're going to get much more accurate reporting. And also, we're not going to get into this mess of liability which I think is blighting the way in which primary health care is dealt with at the moment. So I think at the local level, that's the cultural shift I'd like to see us have, not just for sepsis, but for patient safety generally.
Thank you. So next, I go to Marcus. Any final words?
No, I agree with Alan. I think cultural shift makes sense. It's probably, and I think Mike mentioned that earlier as well. Like approaching this cultural shift, and it does not. I don't believe that it has to be always from a policy perspective, but really that it could be down to the institutional level and approach this to improve morale and reduce burnout and drive this cultural shift down to the physician level and patient level. And I think that is what I would also strongly argue, which would be that this would be probably the biggest effect of getting to that goal that you laid out in zero harm.
Thank you. So Kawaldip, any final words?
I think this needs to be integrated into the WHO's Global Patient Safety Action Plan 2021-2030, and it needs to be integrated with AMR vaccines for life as well, adult vaccination, and it needs to be integrated into other programs as well. So I think the word is integration and family and patient engagement at the center. So let's make this great patient safety story for the Global Patient Safety agenda. And we have the World Patient Safety Day coming up soon on 17th September. So it'll be good to see how we can take this forward. Thank you.
Thank you, Kawaldip. So Mike, any final words?
Okay, thank you. Thanks, Abdulelah. So I'll go for, in the words of a previous Prime Minister, education, 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 and education at three levels. Education to support the patient, so their health literacy improves and increases, so they're given the power to challenge. They're given the power to challenge then the next level, the professional level, whose educational standard often in this field is very low. So we need to educate based on evidence-based interventions that we know will create a will move this into a preventable group. Sepsis is preventable if it's acted on early, and you've showed the data for that. And the third level of education is at the system national level, so that we challenge our politicians to challenge their own healthcare systems. That's where the dynamic needs to play. So we challenge our healthcare systems to change and adopt evidence-based approaches, early intervention, and then a rapid assimilation of care. Thank you.
Thank you very much. So Günther, next. Any final words?
Try to make it simple. We need two things. We need a positive strategy, because if we put patient safety and sepsis as a threat for patients and a drama for doctors and nurses, then all these people will avoid it. If we put it in a positive frame, that it's a chance to create better working conditions and to fulfill the caregiver's mission, then the rate of adoption is much higher. Second, we need better systems. Actually, we have good people and bad systems, and our systems are bad because within our systems there is not enough communication and not enough cooperation. So when we think about our healthcare systems as networks where people can connect and talk and really cooperate to provide values for patients, then we have reached our goal. So strategy and system.
Thank you very much. And last but not least, Neelam, any final words?
Thank you, Abdulelah. As you're fully aware that the Global Patient Safety Action Plan is a roadmap for next 10 years. And its main objective is to eliminate avoidable harm in healthcare. So it's titled as Towards Eliminating Avoidable Harm in Healthcare, and creates a vision, a world in which no one is harmed in healthcare and every patient receives safe, respectful care every time, everywhere. So with that philosophy and vision, The strategies which actually have been identified and as part of the action plan are all towards zero harm. But it's a multi-modal strategy which we need to implement to reach zero harm. And we need policies which are clearly defining that the governments are working towards eliminating avoidable harm in healthcare. We need high reliability systems. We need safety of clinical processes through identifying risk-prone procedures and having standardized procedures. Patient-family engagement and health worker education, as Mike mentioned, their skills development and their safety. We need information research and risk management and very robust reporting and learning systems to learn from where things have gone wrong. And we need very strong synergies and partnerships and solidarity. So I think these intertwined 7 strategic objectives, which are outlined in the Global Patient Safety Action Plan, is the way to go to achieve the zero harm goal. And only then we can, significantly see the outcome of reduction of harm. So far the efforts have been on processes, but I think over a period of 10 years, if we implement this vision through this framework of action, we can actually see a reduction in harm in healthcare. Thank you.
Thank you very much, Neelam, and I would like to thank our esteemed panels, Dr. Neelam Dhingra, Dr. Mike Durkin, Dr. Marcus, who had to leave for another session, Kawaldip, Sehmi, and Alan Donnelly, and Dr. Günther, Jonitz. Basically, my thanks to everyone of the audience, and apologies for not being able to answer all your questions. But please, if you heard any useful information today, so make sure that you share it, not just with one person, but with 10 persons, and ask them also to share that information with other 10 people. And I think this is how we can create momentum and actually, bring down some of these, major challenges that we're having. So with that, I would like to, finish this session, and please carry on and log in to the other sessions, and make sure that you continue with today's sessions and tomorrow's sessions as well. Thank you all very much. Bye.
Thank you. Bye-bye.
Thank you.